Morning, good morning. You all were right on time, and we are starting on time. So welcome, thank each and every, hello? We start on time, we want to end on time, right? Welcome, everyone. Christopher is passing out a release form because we are doing such an amazing job that we want to capture the essence of everything in this room right now. And so if you do not want to be photographed or part of any videos, let us know. Raise your hand. We'll give you a blue wristband, and that way our photographer knows that you do not want to be videotaped. Okay, one over here, Josie. Any others? Raise your hands high. We want to respect your privacy and honor that today. So I'm going to give you a little bit of a historical backdrop. I'm going to give you a little bit of a historical backdrop before we officially kick off everything today. And a recap. In front of you, you have your meals if you want to eat now, but we begin every program with exercise. So if you don't want your stomach jiggling when you're exercising, don't eat now. Eat when the speaker is speaking. You got lots of stuff in front of you. I'll go there really quickly. The release form we will collect a little later. So if this is your first time here, we're honored that you took out time from your busy day to join us. But if this is your fifth time, welcome back. We have a lot of fun, do we not? And we learned quite a bit. So December 2022 marked our 1-year anniversary of hosting this monthly men's program. We kicked it off in 2021 virtually. And next slide, I just want to show you a visual representation. The first program was virtual. We had about 30 men online. And each month we feature a rotating health topic based on your feedback. So we feature a rotating health topic each month based on your feedback. So that post-event survey is how we determine what you want to hear about. And so the next program, we said, hey, I think we're ready to meet in person. It was a hybrid program. We had about 10 individuals on site at a studio in Atlanta, and then several online. And then our first on-site program was here at the Brain Health Center, actually in the parking lot, because we were still very, very cognizant of COVID and didn't want anyone to get sick. So that's why we're still wearing masks, etc. But you said, hey, I want more. So last month marked our record attendance with 115 individuals, men on site, men that look just like you in this room. So give yourself a hand. Thank you for the So the why? Why? Because we're a research center, and you can take care of one part of your body, but really you need to manage all things related to aging, right? Today, we're going to hear from Dr. Monica Parker. She's our Director of Outreach, Recruitment, and Education Board. There's plenty of seats. Come on in, gentlemen. And the Director of our Minority Engagement Board. She's going to give you a Dementia 101, just because many of you are new, and based on those that complete the pre-event survey, you needed to understand what are the risk factors related to Alzheimer's? What causes it? What should I be concerned about? How do I get a proper diagnosis? And so Dr. Parker is going to walk us through that today. And then you're going to hear from an attorney. We asked you, do you have your affairs in order? Is everything up to snuff when it comes to aging as an adult, as it relates to your documents? So you're going to hear from Attorney Carlissa Carson a little bit later. But we do this every second Thursday of every month. We require you to register. That's something that our funders require us. I know you're like, do I have to register again? Yes. So a little bit more housekeeping before I turn it over to John, and then you're going to hear from Dr. Monica Parker. She's going to welcome you and have her formal presentation. I have a little bit of housekeeping to cover today. That is the link. Can you go back to the link? It's on Eventbrite. We always register on Eventbrite. It's if we have your email address, we'll send you an email and just go ahead and register right away for the March program. I think it's going to be a urologist that we're featuring. Okay, next slide. All right. One thing I would ask, because we are recording, take your phones out and go ahead and silence them. When we have to go back and edit the video, it takes a lot for us to try to cover up all that background sound. The video is will be posted to YouTube. So you can go back and watch all of the programs that we've been hosting over the last year. You may miss a couple of things. You may say, oh, I missed that. So you can always go back and watch the program. If you have to take a call, I just ask you to step out right here. The doors in the back, you can step out and take your call. And even the restrooms are all the way in the back to your far left, right where Christopher's waiting. The restrooms are back there. Again, I talked about exercise. You want to participate at your own risk. You can, John's going to get us going. He's going to go a little fast. He's going to go a little slow, but you go at your own pace, okay? Or you don't have to participate. I like this. People say, oh, this program is free. It's not free. It takes a lot of energy and time and money and effort. So I just say it's no cost to you, but we want it to be high quality. We want it to be something that you want to come back to again and again. So we appreciate your feedback. And a lot of you said, how can I volunteer? Not just for research, but just to help us out. So at the end of the program, if you want to support us in other ways outside of research, you can absolutely be a volunteer. This room setup takes manpower. And as you can see, it's the women behind the scenes making a lot happen. So we would love to have volunteers. Or if your organization is interested in hosting a program just like this, we were just at Salem Baptist Church this past weekend with like 120 men for men's breakfast. So if you have those built-in programs, we are more than happy to participate. All right. In front of you are yellow forms, and we're going to talk about those at the end. But first and foremost, we're a research center. If you have already completed a yellow form and said, hey, I want to be in that research that Dr. Parker talked about, how do I get involved? Well, you have to fill out that yellow form, and that gives us permission to contact you. But answer the phone if we call you, all right? And don't feel obligated that you have to fill it out. And if you've already filled it out, you're in the queue. We're about 2 months behind in getting connected with you, but someone will reach out to you. There's a post-event survey I mentioned, and we always have a Q&A, and we'll be moderated a little later. We can't answer everything today, but if you have questions, go ahead and write them down on your notepad. We can collect those and try to get through as many questions as we have. We'll moderate the Q&A and crisscross the room today, but for the most part, we want to try to get through your questions. There was one program where people just kept standing up and telling us about their medical history. We want questions. Okay. You've done the photo release form. And then I just want to say thank you to all of our personnel, to our volunteers, our personnel, and invited guests. So Dr. Parker, how do you want to do our giveaway? Put her on the spot, sorry.
Those who brought someone.
You want to do it now or after John? Okay, all right, because men are still trickling in. Okay, without further ado, come on up, John, and while he's coming up, the next voice after John you will hear is Dr. Monica Parker. As I mentioned, she's a geriatrician with over 30 years of experience and has been leading this effort for nearly going on 2 decades, thankfully. She's going to do her presentation about Dementia 101 and give you a little bit of backdrop of how we got here today. I also want to thank Mr. Karen Graves, Dr. Clint Dye, Dr. Cornelius Flowers, and David Dorman. They've been meeting every month and looking over your post-event surveys and sort of analyzing them and deciding and determining how do we move forward. So we appreciate that core group of men who take time out of their schedule every week.
Thank you again. I'm so used to having a bunch of women in here. To see all us men in here, it is a treat for me. Yeah. Instead of having all these women to myself. So, if you're new, the rule is go at your own pace. If it's something you can't do, don't do it. If the doctor says don't do it, do a little bit. Okay. The motions that I'm going to be doing is teaching you things you can do in the chair to stay stable. Every motion that I'm doing with my upper body, I'm emulating every machine in a gym. We're going to do a little bit of rehab. If I say hamstring, we're working the quads to save the knee. Twisting the waist, working on that core and lower back. So let's get going. Let's get it warmed up. Go warm it up. Right leg straight. Then lower back. Get that upper body. Go.
So nothing right from the lens, so like, so keep thinking about it. Like, you know,
I can make one time.
do you believe in the police just to me, but they make us do each other. I'm really talking about.
Let's go. Every day of the weekend. Depends on. What? And just put out the light, man. Let me tell you about it. Hey.
Dancing counts as aerobic exercise. So I want to say thank you to all of the gentlemen who've assembled, and we have a really great crowd today, kind of like it's something, huh? Just before we get started, I know you guys like to be rewarded for your attendance, and we want to make sure that we stay consistent with what we've been doing. So last time we were going to do something a little different. How many of you brought somebody today? Stand up, please. Stand up. Okay. So I need you to stay standing for a couple of minutes because Mr. Julius and Witt are going to circulate and give you an index card. And on this index card, I need you to put your name and the name of your guests on that card. So stand up. Just stay there. If you've gotten your index card, sit down. Please. I can sit, please. Not spouses. Okay? Not spouses. In all fairness, this is a men's health discussion group, and I love the ladies for getting you here, but this is for men. That's what I've been told, and I've got to keep saying this because the men that give me my orders to make this program say, we want a men-only kind of space. So we're rewarding men for their good behavior. Got it? We almost done, Julius. There's a gentleman standing back there. And when you finish completing them, if you'll hold them up Mr. Julius and Mr. Witt will come back around and collect them. And that's how we're going to be giving you your gift cards today. If you've completed filling it out, hold it up so that the gentleman can come and collect them. We're trying to figure out how we can get more people in here so the next time you might not have tables. We're just trying. We're trying to figure it out. As Cornelia said, this is free to you, but not to us. So we got to figure out how we got to maximize stuff because this space is free. We get bigger, we'll go someplace else. You can give us some suggestions in your evaluation sheet that's free with free parking because any place on Emory, 3 hours is $6, 4 hours is $8. And I know you don't want to pay for parking, right? Got it, Cornelia? Okay. Have we gotten all the cards? We gotten all the cards? Okay, thank you. Okay, I'm going to start because according to our pre-event survey, almost 60% of you, this is your first time. So I'm going to ask you to raise your hand because that's why we're going to do this the way we're doing it today. How many of you have never been here before? Just raise your hand. I just want to see. That's a lot. So with your continued support and your suggestions, we're going to make this second Thursday event what you want it to be. And of course, we're going to continue to reward you for your participation one way or another. But because so many of you are new and so many people want to know a little bit more about Alzheimer's and dementia and what they are, I'm going to do what I call Dementia 101. It's kind of like a primer. And then when I finish, you're going to hear from our attorneys from Emory School of Law. Emory School of Law does a lot of public service projects, and part of what we do here for our discussion group and our educational outreach is make you aware of resources that you probably didn't know existed, but are certainly available to you. So for the benefit of those of you who are new, and for those of you who are seasoned, this is a little bit of a refresher about brain health. We have you start off with John all the time because exercise is good. And for those of us who don't golf, and I know you golfers think you're hot stuff, but you get more energy if you walk, right? Rather than ride the cart. All I know about golfing is I man the hole-in-one and I drive the drink carts for golf tournaments. And I know that you get more exercise if you walk. Okay. So that being said, there are all kinds of ways to get exercise, and chair exercises like John starts us out is one way, but dancing is something we all like to do. I don't care if you're really good at it or not so good at it, but 5 or 10 minutes in front of YouTube with your DJ is a lot. Okay, so I can't see this from here. Am I supposed to? No. Okay, so I need to help you understand what dementia is and what it is not. And so the correct nomenclature or the proper word is not dementia. It's not old timers, it's Alzheimer's. And when we start talking about dementia, there are lots of different kinds of dementia. But the new terminology is called neurocognitive disorders. We recognize that this is a spectrum of disorders that affects people. And all of the things that look like dementia or Alzheimer's are not all the same. So first of all, dementia or a neurocognitive disorder is not normal. Don't write anything down. I'm going to give you some resources and I'll tell you what to write down. I just want it to sink in. Okay, don't try to take notes. This isn't class. This is for your edification and you can go back over it. Okay, I used to teach English, so take your time. Just listen. All right. Dementia or neurocognitive disorders are not normal parts of aging. You shouldn't have deficits or difficulties functioning with your brain as you get older. Things may take a little longer to process, but you should still function pretty much the way you did when you were younger. Just takes a little longer to get going. Okay, so what is a neurocognitive disorder and how do you know what it is? There are maybe behaviors or symptoms that are interfering with your normal social or occupational function. And the reason this is important is because if you get a correct diagnosis, and let's just say you're not yet 65, you can leave your job not so much because you're incompetent and your performance reviews are poor, but because you have a medical illness that's creating a medical disability. Do you understand the difference? I've had patients who have come because they've had job performance issues, and they'll say, I can't remember, and they don't want to acknowledge that they're having those kinds of problems, so they say there's nothing wrong. And they have poor review after poor review, and they subsequently get relieved of their responsibilities, and they leave without their retirement benefits. They leave with nothing. So it's really important when you notice that somebody's having difficulties functioning, doing their jobs, interacting with you on a social level, to make sure that you get that addressed, but particularly while you are working. It's better to acknowledge that I'm having difficulties because I have a medical problem, and this medical problem is making it such that I can no longer perform my job. And then you can go about, and Carlissa will talk about disability to some degree, but the important thing that I want to stress is that everything that looks abnormal may be, but it's not for you to decide that you're disabled. There has to be a lot of medical documentation that goes along with that. So it's really important when you see people who are normally good, all of a sudden not functioning well. They need to be evaluated. Right now, for any neurocognitive disorder, there is no cure. I was on a program yesterday and they said, come on, let's be clear about what's cure and what's not. Right now, for any neurocognitive disorder, anything where you have neural degeneration, there is no cure. There may be some treatments that are palliative, which may slow it down some, but there is no cure. We have a cure for the syphilis, right? What's the cure for syphilis? Antibiotics, penicillin, okay? You get a shot of penicillin or enough of them, depending on how often you get infected, you get cured, all right? But you don't get cured from Alzheimer's, from Parkinson's, from any other neurodegenerative process. You understand the difference now? Okay, we don't have a cure for any of them. Okay, and it's real important to understand what's going on because some of these things that you're observing may have a medical reason or something that we can point to that's causing it that can be eliminated. And if we eliminate that, we can revert back to something that might look like normal. So, in the spectrum of neurocognitive disorders, and when we start talking about these disorders and those of us who are older than 50, and I'm going to go back to what you're familiar with, dementia, but it's a neurocognitive disorder. Got it. There are several different types of neurocognitive dysfunction. The most commonly researched is what you're hearing about is Alzheimer's. But more commonly, people have a mixed kind of neurocognitive disorder or a mixed dementia. If you are a person who has had a stroke, you have more likely what we call vascular dementia. That's a result of poorly managed hypertension, high cholesterol, diabetes, anything that leads to that, irregular heartbeats, atrial fibrillation, heart disease. That's what we call vascular dementia. Just because you have vascular dementia, does that mean you don't have Alzheimer's? You can have both existing in the same place. Ted Turner has something called Lewy body dementia. That's a different type of dementia that has a different kind of pathologic process that goes on that is different from Alzheimer's, that is different from the vascular dementia that we talked about. We don't really know as much about Lewy body dementia. We don't know as much about frontotemporal dementia, which is shrinking of the frontal part of your brain. And then you have other dementias. Now, what are some of the other dementias or other neurocognitive dysfunctions? Chronic alcoholism leads to something called chronic alcoholic encephalopathy. That's a reason to be dysfunctional. Somebody who has untreated HIV/AIDS infection is likely to have a problem with the way his or her brain works. In all of these people, you can have a mixture of all of those things. It's like, okay, so what did she have? I have one patient, her daughter's a part of our longitudinal research registry. And when she donated her brain, we found evidence of Alzheimer's. We also found evidence of Lewy body dementia, and we certainly found evidence of vascular dementia. She was a retired African-American service worker from Grady, and she said, yeah, you can have my brain, and I'm forever grateful to her because we wrote a paper on the differences in people of color and dementia and what it looks like. And she was one of the persons, but she wasn't the only one, who showed that in African-American people, there's a mixture of pathologies or differences in why brains don't work. So that's the important piece. So what do we look at when you are being evaluated for brain dysfunction or neurocognitive problems? So everybody says her memory's not right, his memory's not right. Well, memory isn't the only thing that is measured when people start to have problems with the way they process information. You can read along with me. The top one is complex attention, which is what we are all doing right now. Executive function, which is some skill that we've learned over time that all of a sudden we can't do. Maybe it's something like driving. My favorite one is golf, because I had an executive who used to see me, he said, you know, I'm on the golf course, but I forgot how to play golf. Okay, just for you golfers. Okay, somebody who forgets how to play golf, somebody who forgets how to play bridge or cards or cook, follow an instruction, doing things that they were normally doing, and they can't do it anymore because it's a process, executive function. Loss of learning and memory, I think that's pretty self-explanatory. Perceptual motor, getting your body to move from one side of the room to the other, using your legs, using your arms, coordinating that activity. That's a brain function. Okay, and if you can't do that, and we know that there's a deficit there, there's a problem. And then language. A lot of people using the right words, recognizing people by their correct names or their genders, whatever that is. That's a language, correct use of language. People whose first language was not English revert to their original language when they start to have problems with their memory or the way their brain works. They mix up the English and the Spanish or the English and the Italian. Social cognition, doing appropriate things in the right places, peeing and pooping in the bathroom as opposed to your chair in front of the television set. You know, those kinds of things. I bring that one up because that's the one that bothers family members the most and embarrasses them the most. And that's when usually people start bringing people to the doctor for an evaluation. We can get over repetitive stories and that doesn't bother us. And we don't really care sometimes that some people don't remember things. But what we do care about is, can you be left alone? Can you take care of yourself? Can I depend on you to take yourself to the potty by yourself and not soil yourself in public or mess up my furniture for some women, some men too? Can you feed yourself? Can you fix a meal for yourself? Can I be okay leaving you alone while I go to work? Those are things that bring people to the doctor, and they're bothersome things because we miss a lot of the little stuff as we go along. So deficits in 2 or more of these brain functions constitute what we call dementia or a neurocognitive dysfunction. That means that you need to have it addressed. Well, what's causing it? Don't know. Don't have a clue yet. But there's 6 different things that we measure when we look for and evaluate people for dementia. Not just memory loss. It's more than memory loss. Got it? Okay, so how do you prevent brain disease and how do you maintain brain function? A lot of the stuff that we've talked about: exercise regularly, manage your chronic diseases, eat better, consume a heart healthy diet. If you have hearing deficits and you think you might have a hearing deficit, get it checked as soon as you think you might have one, simply because that interprets what you hear and see. And that interpretation, that executive function in social cognition is all a part of that. Okay. Identify and treat depression and mood disorders. Why? Because we do have treatments for them that are effective, and untreated, unmanaged depression can masquerade as dementia. It looks like that. And engage in regular intellectual activity, anything that makes your brain work. So if somebody's already got problems with how their brain works, don't try to give them Sudoku and all this other stuff to do, because that's frustrating to them. If they can do a crossword puzzle, great. If they can play checkers or continue to do something that they enjoyed, great. But don't stick a book in front of them and say, you need to do this because this is a good brain exercise. That's frustrating. and it frustrates them and it makes them feel bad. So don't do it. If you are upright and you are functional and you can do that, you can do all of that. But don't expect somebody who's obviously having difficulty to do and learn something new because they just can't do it. And don't get mad, because that's what we do too. Okay, manage sleep disorders, sleep apnea. So the best way that I can explain sleep apnea is when you're sleeping, you're not breathing well. And when you don't breathe well, that means your brain's not getting enough oxygen. And if your brain's not getting enough oxygen, cells are dying. So when women have babies and the babies' brains don't get enough oxygen, they are born with some significant functional and learning disabilities and problems. Same thing with sleep disorders. Okay. Manage and treat chronic disease. Most people who have a dementing disorder don't die from the dementing disorder. They may die from the fact that they didn't eat or drink because they didn't recognize the urge to eat, drink, or defecate, or any of those sorts of things. But most people with dementing disorders die from something really rather organic. We didn't manage their diabetes. We didn't manage their heart disease. So they died from those things. Okay. Avoid obesity. Everybody knows that being significantly overweight taxes your heart and makes it more likely that you have cardiovascular problems. And cardiovascular disease is still the #1 killer of all adults in this country, regardless of ethnicity or gender. But obesity is a risk factor for cardiovascular disease and heart disease. Smoking for the same reason. So how do you address these behaviors? Do you go to the golf course? Do you go to the club and discuss them? No. You go with your loved one and or the person affected, and you go to the doctor and let the doctor know what you're observing. And be very clear about what you're observing and tell that person what you're seeing so that they can address those things accordingly. One of the things that we will do is make sure that people are taking the right medicines for all the right reasons. Like, I want to see a specialist. I want to see my PCP. No, you got to start with the PCP because it's his or her job to make sure that all the metabolic and physiologic things are where they're supposed to be. Are you taking all the right medicines for all the right things that you're supposed to be taking them for? Are you taking them in the proper dosage? Is there a side effect that you may be experiencing? That's the primary care doctor's job. After that's okay, it's then that doctor's job to order the brain MRI to make sure that there's nothing acute going on. And then after that, we'll send you to the PhD, the neuropsychologist, to do the testing that goes along with measuring those 6 different brain functions that I talked about earlier. And when we've got all that together, then we send you to the neurologist who may do the lumbar puncture where we look for A beta and tau proteins. But regardless of what your type of dementia is, that is the kind of evaluation that you're going to get. You're going to have to be tested for syphilis because, yes, we still have latent syphilis around and there's no Tuskegee, right? Lots of people don't get tested for that. Lots of people may have HIV infection that's been untreated or unmanaged. They may have cardiovascular disease and a cardiac arrhythmia or atrial fibrillation that hasn't been managed. Maybe they have untreated, unmanaged thyroid disorders. Those are the things that your primary care doctor should be doing when you're doing an evaluation. When we've done our job, it's then our job to refer you to a neurologist for additional testing. So if everything's done well, everything gets done well in the first stop. And then you have extra stuff. You can't just go to a neurologist with no information. It'd be helpful when you go there to make sure he knows what medications you're on, to look for things. He helps that person know what else to do if you've already got a brain MRI. Because then if we are selected, we can put you in a research study and probably get a PET scan and confirm certain things. If you're super wealthy, maybe we can order a PET scan at $6,000 or $7,000 a pop, and you can pay for it because insurance doesn't. Research does. Okay. If you're 65 years of age and older, we want you to get an annual wellness visit where you go with your primary care doctor and check for those things that need to be checked for. These are the things that we check for: medications, immunizations. Are you doing everything to keep yourself healthy? That's why we stress exercise when you come in here. We do the screens for dementia. We're not going anywhere. Okay. Those are the things that I told you that we do. And this last slide, second to the last slide, lets you know that there are over 150 different studies that are going on in the United States at any one time. Research is largely funded by private industry along with the federal government. All of the research, I won't say all, but a good number of the research centers, there are 33 in the United States that are dedicated to the treatment and research around Alzheimer's, are all funded by the federal government. And the federal government gets money from you to operate these centers. The state of Georgia operates 5 memory assessment centers around the state that do the same kind of neurologic evaluation that we would do here at Emory. That's paid by Georgia taxpayers. Memory assessment centers, if you've been here before, are here in Atlanta at Grady, in Albany, in Macon, in Columbus, and Augusta. And they've just appropriated more money, so we'll probably have some more memory assessment centers in the near future. Finally, the important thing is neurocognitive disorders or dementias are not inevitable as you get a little bit older. There are a number of different things that figure into the evaluation and diagnostic process. Just marching into a doctor's office and demanding to be seen and taken care of won't get it. And calling me or anybody like me isn't going to get you what you want either. Simply because the healthcare system doesn't work that way. Might have worked that way 30 years ago, but it doesn't work that way now. Research right now is focused on developing better diagnostic tools and more inclusive diagnostic tools that make it more likely for people like in this room to get an evaluation, blood biomarkers as opposed to getting the lumbar puncture. And the PET scan that I talked about, there's only one FDA approved tool really used for diagnostic purposes, and that's the amyloid PET scan. It's primarily a research tool. And as I said before, it's not paid for by research. If you have a lot of money, you can probably get one done. But most people who are going to get one are going to get one through research. And there's a lot of requirements that go into that. And the last point, and the most important thing that I need you to understand, is that there really is no cure. We understand cure, right? Versus slowing down the process. There is no cure for Alzheimer's right now. There are medications that have recently been approved, but none of those things is curative. It's not a chemotherapy for Alzheimer's. And this medication, if you have HIV, head trauma, chronic alcoholism, these medications are not for any of those. It's not even for Lewy body or the frontotemporal. These medications are strictly and only for Alzheimer's because they work on reducing the amyloid and protein buildup accumulated in your brain that's related to that. And it's still not clear that removing the amyloid that builds up restores function, such that people revert back to the way they might have been if their cognitive facilities were all intact. So that's it. There's some resources. Okay, Deja, you got to go to the next one. Now, this is what I want you to write down. You want to know where to go to get some better information? This I want you to write down. www.alzu.org. www.alzu.org. This is a primer. It's kind of like a comic book. It's an easy read to help you understand all that goes on when we start looking at brain dysfunction. You can look at the Alzheimer's Association, but that's the only one that I want you to read right now. We have our own website, and you can go on there and archive, get copies of our different programs. You have a website up there for the Alzheimer's Association. And then this one, this is the other thing I want you to write down and go Google when you get home. It's the Lancet Commission Report on Dementia. 2020, LANCET, Lancet Commission Report on Dementia. That's the only thing I want you to do. And that tells you what you can do to prevent dementia and live a little bit more healthfully. And they've updated this since it started in 2017. They updated it in 2020, and there's another update in 2022. But this is a landmark report. It's all we have, all the information we have to date about research and Alzheimer's. And keep in mind, all neurocognitive dysfunction is not Alzheimer's. It may be other things, and it is a process. It's not an instantaneous thing. We don't have a single test that gives you that diagnosis. Cornelia? Okay, you look at Cornelia, but a lot of these programs have gotten a whole lot better because Ms. Dorbin, who is our assistant co-director of the, well, we do everything. But more importantly, all the logistics, all the fine tuning is done by Mrs. Dorbin. So please give her, I have to acknowledge her. I also have to acknowledge Ms. Crystal Davis and Deja Danzy. Those are the people buzzing back and forth around here. We have several different research projects and we have several different coordinators who work on those projects. But the primary staff responsible for getting you in this room today is Mrs. Dorbin, Ms. Davis, Ms. Danzy, and Dr. Parker. Thank you for coming. Questions? And then I'm going to turn it over to Carlissa. Okay, over here, this gentleman I saw first with his raised hand. We need mic movers, gentlemen. Stand up. Can you scream?
I got you. Where are you? Where is he?
Shout, they yell. Okay, men don't scream, they yell.
There you go.
We've got 5 questions.
How you doing, everybody here? My name is Larry Watson. My medical history, no, I'm just kidding. Every time I come, that's what happened. I wanted to present this to the ladies for Valentine's Day and thank you sincerely. I had a stroke 1 year ago this week. And even though I do appear to be the youngest looking person in here, I'm only 52, but it happens. And I thank you because I am concerned about my future. So ladies, thank you. I want you to share this gift from all of us. And I love you and I thank you.
Thank you.
I'll make sure they get this when I'm finished with it.
Okay.
Okay, questions. Yeah, just for time and just to make sure that Dr. Parker will answer your vital questions, we want your questions in a question format form. Okay?
Okay, Cornelia told me I only have 5, so this is 2.
Oh, okay.
Yeah, real quick. I saw you say other for as a different form of dementia. And I want to ask you the question of like when people have a lot of concussions early, would that flare up in?
That's a very good question. The question is, when people have a lot of concussions early on, does that lead to dementia? If you've been paying attention to the news, yes, chronic head trauma, chronic traumatic encephalopathy, CTE is what they call it, does result in cognitive dysfunction. A lot of football players have this problem, but not only football players, people who've been in the military who've suffered significant head injuries, but also victims of domestic abuse with lots of head injuries. So it's not just football players, it's anybody who's had lots of head trauma from whatever cause are at risk. And it is cumulative. That's why you see in the NFL, they're getting real picky about pulling people off the field if it looks like they've had a concussion. Okay, David.
One more question here.
Okay. Yeah, my question is, I have a friend, and you was talking about dementia and Alzheimer's as far as the memory. Doesn't really have, a lot to do with it, but
It's not the only thing, is it?
right, not the only thing. And my question to you is, I've, been suggesting him to go check it out or whatever. And what could I do? I guess I'll invite him to come here, but he works, so he's not able to come.
What you can do with what you're learning and what you're going to learn when you go to www.alzu.org
Right.
is you're going to sit down with him and make a doctor's appointment with him, and you're going to take him to the doctor
Well,
and make sure he gets that address.
well, he's married, but I'm just saying.
I'm just saying.
I understand. I
I
understand.
gave you the plan.
I got you. Well,
Okay,
you
but
know.
the point is you've got to get to somebody with the information, the resource, and the knowledge to be able to help you with that. Okay, I see this gentleman in the back. No, this one, in the back. That's right.
Thank you. I was 52, 25 years ago. Do the math. My question is, you indicated that there are some memory or dementia assessment centers. Is there a fee for the service that's provided?
Okay, very good question. Okay, this is the 3rd thing I want you to write down. Georgia Memory Net. You can Google it. It started here at Emory through community conversations and faculty members here, including Dr. Levy, Dr. Law, Dr. Parker, and Dr. Hepburn in the School of Nursing, Dr. Johnson from the geriatrics. We persuaded the Georgia legislature, along with the Alzheimer's Association and other people, to allocate $5 million to establish these centers. The way you get to these memory assessment centers is via your primary care doctor. Your primary care doctor has to write a referral, send accompanying medical records that include your medications, updated laboratories, and any evaluation that they have done. And that is sent to a central repository. It's usually done through the Alzheimer's Association. I think that's part of what it is. But the primary care doctor refers you into the Georgia Memory Net. The Georgia Memory Net then schedules you for an appointment. Don't ask me for the names because there are different people at each of the sites that's different. Like Albany's operates out of Phoebe Putney Hospital. All of these operate within the construct of a medical provider training program. In Macon, it's Navicent Healthcare through their family medicine program. In Augusta, the same thing. And in Columbus, as I understand it. So the rule is if you live outside of Metro Atlanta, or even if you do, because we have an assessment site at Grady, your primary care doctor refers you to the Memory Assessment Center, and they help conduct the evaluation. They provide social service supports and resources for the family member, depending upon what their diagnoses are. So, and whatever your insurance is, pays or doesn't pay, that's how it's done. I can't vouch for what's this cost, what that costs. Healthcare is a very complicated thing, and there's not an answer that's appropriate for everyone.
Okay, Dr. Parker, we have one more question in this area, and then we're going to go into the next presentation.
Okay, where are you, David? I don't see it. Okay.
Dr. Parker, I've been a participant in memory testing at Georgia Tech for the last 7 years, and I was just curious, they actually pay you to test your memory. Does Emory Brain Health Center have something like that?
Okay. Now I'm going to talk about something that's really kind of ugly, but how many doctors are over there at Georgia Tech? Medical doctors. Okay, how many doctors are at Georgia State? Medical doctors, MDs, not PhDs, not EDDs. Okay, just about all of the research projects that you may participate in will give you some kind of financial stipend that pays for your transportation or something like that. If you go to the Plasma Donation Center, you get a whole lot more money than you did when I was in college. It was only $25, but now I understand you get hundreds of dollars. Okay, but if you are a participant in anybody's research study, almost all of them have some kind of compensation that is associated with it. If, for example, you are somebody who has, let's say, cancer that's not responding to traditional methods or treatments, they may invite you to participate in the study and say, this is an experimental treatment. We're still going to treat you with what we know to treat you with, but there's an experimental thing that we're doing now. You can opt in to try it because the cancer that you have right now isn't treatable or manageable with anything else. And they may compensate you, but anything that is a normal part of your chemotherapy and oncology visit is going to be paid for by your insurance or not. It's not going to be paid for by that research program. So different research studies will compensate you differently for what it is you do. If you're answering a questionnaire, maybe they'll give you a gift card for $10 or $25. If you answer a questionnaire and you draw some blood, you may get another gift card. And they may have 4 things they want you to do throughout the study. And after you complete each step, they may give you a gift card or something, but you don't get paid for research. Okay. I don't want, and it's a really good question. I'm just trying to help set the stage for you because we can't pay you for research because that's viewed as coercive. There are some people who may have need, and I sit on the IRB review committee, and I was mad about a particular HIV study, not HIV. This one was had to do with schizophrenia. I said, well, We promised them a gift card. We'll give them $50 if they come do this. So I said, but that's coercive. Well, nobody's going to refuse it, Monica. And I'm like, but that's coercive, you know? And the rule is we can compensate you for your parking, your transportation, and maybe give you something to help feed you. But we don't, as a rule, pay you for research because it's reviewed as bribing. I guess that'll be the easier way to do it. Or if you don't do this, well, if you submit to my study, I'll make sure that you get treated. That's not ethical. So there are differences. So the take-home point is that with any research study that you participate in, they will offer you some token that may be financial to lessen the burden of participation for you. Now, if I take a whole half day to go do a study that the coordinator didn't show up for or the machine was down for, are they going to compensate me per hour for the time that I wasted? No, that doesn't happen. So they're in the field of research. We're starting to look at what is equitable compensation for what we're expecting people to do. It's not taken place yet. It's being talked about, particularly when it comes to minorities. You don't want to give somebody something. You can't say, I'll get you treated if you do. That's not ethical. Does that answer? Okay. Okay. Our next presenter is Carlissa Carson from Emory School of Law. She's going to talk to you about the kinds of documents that we need to have as we're getting a little older and what some of the complications of being unprepared are. It's like, well, what does this have to do with my health? It has everything to do with your health. If you roll up in the emergency room and you're unable to speak for yourself and to direct the care that you receive, you might not get what you asked for. Okay. If you have a terminal illness and you don't want to be put on a ventilator, somebody in your family who's not on the same page may put you on one, and you may be a vegetable for years to come. So, Carlissa.
All right. Hello, everyone. Hopefully everyone can hear me. It's so great to be with you guys here today. So thank you all for inviting me. I am Carlissa, and I am an attorney, and I work in Emory Law's Volunteer Clinic for Veterans. And so what we do is we assist military veterans living in Georgia who are low income. Now, a lot of people ask us why we have the low income requirement. Well, there's a whole lot of veterans, and there's not a whole lot of attorneys who do veterans benefits work, and we like to reach those that are most in need. So that's why we do have a low income requirement. Next slide, please. And if any of you in this room are veterans, or perhaps you have a spouse or a sibling or, a child or someone who might need our help, these are our low income standards. So we consider you low income if you don't make more than 200% above the federal poverty guideline. Next slide, please. And this is our team here. Again, I'm Carlissa, and I'm here with Dr. Hull today. He is actually a law student volunteer in our clinic. He got a PhD and then decided he should have a JD as well. So he's going to speak a little bit later today. And we have Dean Rita Sheppy, who provides administrative support for us. And Drew Early used to be our clinic director, and then he decided he wanted to enjoy retirement since he's pushing 70 now. But Drew Early probably knows more about veterans benefits law than anyone in the state of Georgia. He graduated from West Point. And then he did some time with 10th Mountain. So those of you who have served in the Army know what 10th Mountain is all about. So, and then, of course, I'm up there as well. I spent 9 very long years in the United States Army. I was an MI officer and a judge advocate. And then I decided it was time to fly. So I transferred over to the United States Air Force. So I don't know if we have any Air Force vets in here. Okay, we got some. Awesome. So I'm actually staff judge advocate for the 117th Air Refueling Wing now in the Air Force Reserve. And as of April 27th, I will hit my 20 years. Yeah, so I'm excited about that. Thank you. Thank you. And to those of you in the room who have served, thank you so much for your service. Next slide, please. We work specifically in 3 areas. So I said earlier, we work with military veterans who are low income living in Georgia. Well, these are our 3 areas of focus. So we do VA disability benefits appeals. So when you get that nasty letter from VA and it says you've been denied your claim, you typically have 1 year to refile. So that's where we can step in and we can help you with that appeal process. Some of you might be outside of that 1 year appeal period, but you have some new information. Maybe you have some new medical records or whatnot. And then you can file what we call a supplemental claim. So that's also something we do under this umbrella term, VA disability benefits appeals. Some of you might be service connected, and let's say you have a 100% disability rating, and you get this unpleasant, unwelcome letter in the mail from VA saying, you know what, we think you're much better now, and we're going to reduce your rating from 100% down to, let's say, 50%. So that's something else we can help with, is ensuring that you have the proper rating from VA. Another thing we help with is rating increases. So let's say you were rated at 50%, but you feel like your condition has worsened over time, and you feel like you should actually have an 80% rating or a 100% rating. And, you know, that's important because the higher your rating is, the more money you get put in your pocket each month. So that's something else we do. We also do discharge upgrades. So sometimes a service member is given a less than honorable discharge, and it's due to circumstances beyond their control. Let's say you are suffering from post-traumatic stress or a TBI. Maybe there's military sexual trauma, major depressive disorder. Maybe these conditions caused you to turn to drugs or to alcohol, and then you got into some trouble and you got pushed out with a less than honorable discharge. Well, we can step in situations like that and try to help you get your discharge upgraded from wherever you are, hopefully to honorable. Something else we do is basic estate planning, and this applies really to everyone in this room because, as Dr. Parker was mentioning earlier, everyone needs to have their affairs in order. Everyone needs to make sure they are doing what it takes to be in the driver's seat of their own life. So I'm actually going to talk more about basic estate planning, and we'll touch a little bit on disability benefit stuff because, again, I know about a third of you in this room are veterans, but I really want to highlight the stuff that applies to everyone. So those of you who have not served can still benefit from the presentation, of course. Next slide, please. Okay, so one of the simplest documents you can prepare for yourself is the Advanced Directive for Healthcare. Now, I know a lot of you have heard of a living will and a durable power of attorney, so don't be confused by all of these fancy terms. What the state of Georgia did recently is combine these 2 documents into one. And so it is now these 2 documents combined into one form called the Advanced Directive for Healthcare. So really, this is the only document you need when it comes to directing healthcare decisions. Another great thing about this document is it does not need to be notarized. So it does need to be signed and it does need to be witnessed, but you do not have to take this document to a notary public. So that makes it a little bit easier. And you're going to appoint someone called a healthcare agent. And you write this person's name down on the form, and they will carry out healthcare decisions on your behalf. An important thing to note is this is only effective if you are incapacitated. So if you are willing to make known your healthcare preferences, feel free to do that. This document is not going to conflict with that. This document really comes into place and becomes effective if you, let's say you're in a car accident and you're in a coma, or, let's say you've got a feeding tube and you can't speak or something like that happens. This is a great document to have because your physicians and your family members can look and they can see that you wrote down your preferences. And so it guides them in that healthcare decision-making process. The form also on part 3 allows you to appoint someone called a guardian. And this is someone who can step up and handle your affairs for you, once again, if you become incapacitated. And the court will give deference to the person that you put on this form, so long as the court believes that person will serve your best interest. So you can not only use this to appoint a healthcare agent, you can use this form to appoint a guardian. And this form is actually available online as well. So you can just, Google Georgia Advanced Directive for Healthcare, and you can print this off and fill it out. Again, it doesn't have to be notarized. And we would recommend that you make copies of it, give it to your family members, give it to your primary care physician, so your PCP. And that way everyone knows what your healthcare preferences are. Divorcing. This is a question that a lot of people ask. So let's say you put your wife on this form and you later divorce. Well, that will effectively remove your ex-wife as the healthcare agent. And I would suggest that you fill out a brand new form at that point. That's a life event that should trigger, you to fill out a new form. All right, next slide. So brand new as of July 2022, Georgia now has something called a psychiatric advance directive. And this speaks directly to your mental health care. So I would suggest that you also fill out this form if you haven't already done so. And it really contains your mental health care preferences. So, do you want to submit yourself to electroshock therapy? Not only that, but the person you appoint here can give their consent to have you admitted. They can also give their consent to have you discharged. So it's also important, as I'm sure you've already recognized, that the person you name in this form is someone who can be 100% trusted, someone who will act in your best interests. And it's probably important, too, that you have discussions with this person. Let them know that you have appointed them. And, if there are any questions about your preferences, that you answer those for this person so they're confident that they're making a decision that is best for you and that reflects your preferences. This must be signed while you are still mentally capable. So in the law, of course, you have to be mentally capable of entering into contractual obligations. So it's really important to get these documents filled out and signed before you get to, let's say, the later stages of dementia, for instance, because the law has to ensure that you understand the significance of the document that you are signing. And these are this is just a list of things that your mental health care agent can do for you. I mentioned earlier, they can consent to, authorize, refuse, or withdraw consent regarding mental health care treatments, regarding specific medications, and they can even contract for, care in certain mental health facilities. So these documents give agents a lot of power, and just be, mindful of that again when you're selecting your agent. All right, and now I want to move into some common veterans benefits, because again, I know several of you in the room have served, and even if you haven't, maybe you know someone who has. And so one important benefit is aid and attendance, and another is housebound benefits. And I'm going to let Andy come over and talk to you guys quickly about these two benefits.
Thank you, Carlissa. Appreciate it. Thank you all for having me here. I'm going to talk to you a little bit about a couple of benefits that can be available to you, sort of in addition to your VA pension that you already are getting. First of all, I want to kind of go through is the VA aid and attendance. So basically, as you can see here, this can provide sort of an additional monetary amount up to about $2,400 a month for a married veteran, and then about $1,300 a month for a surviving spouse without any dependents. If you do have a dependent, it sometimes can increase just to make it a little bit easier, more affordable for your family. Also, I just want to say as well, just to not only with what I just said, but everything else on here, just to cover my butt. I am in law school. I am not an attorney, so I cannot give legal advice. This isn't my like legal advice or anything. I'm just letting you all know about some of this stuff. I want to make sure, or else the law school and Carlissa will get very mad at me for saying otherwise, as representing myself as an attorney. So. Moving on. So you can be you can actually be eligible for this benefit if you get, you know, a normal VA pension and if you have one of these requirements. So there's a few things. One might be, you know, if you need another person to help you with a lot of very sort of basic daily activities, such as bathing, feeding, or dressing yourself. If this applies to you, like if you have difficulty with this and you need someone to kind of attend to a lot of these things with you, then you might actually be you might be eligible for this. Also, if you have to stay in bed, if you're
Some of our veterans, people in here are veterans, but maybe they have a remaining spousal, like a mother whose husband was a veteran, but the veteran is dead. Can they get this?
Let's see. What was it? Let's say one more time. I'm sorry.
If the veteran is dead and the spouse who may be older and aging, is she eligible for aid and attendance benefits?
I believe, there is a surviving spouse without, if there aren't any dependents, if there is a surviving spouse, they can actually get up to $1,300 a month. So this might help for some of y'all if you're wondering. Yeah, definitely. For parents, I don't know. Just one second. Let me
just address that. So typically speaking, veterans benefits flow to the veterans. So the general rule is they do not flow to spouses. However, there are a few caveats to that. I'm actually going to talk about DIC here in a moment. Right now, Andy's talking about aid and attendance and housebound benefits, but I will talk about DIC here in a moment, and that is specifically for spouses. Andy later on is going to talk about what's called spousal pension. And so that is another benefit for spouses. So we'll get into that in more detail here in a moment, but just the general rule is veterans benefits flow to the veteran.
Thank you. Thank you.
And these slides are going to be emailed to you. Thank you. Sorry for the interruption.
Oh, it's
Slides
okay.
will be emailed to you.
No problem. Thank you. So besides, having a problem with attending to your daily activities, or also having to stay in bed, either you're bedridden the whole day, or you might sort of think, okay, I can maybe get out, a couple hours a day, maybe to the living room or something like that. But if you're spending most of the time in bed, you also might be eligible for this aid and attendance benefit. Also, if you're in a nursing home, sort of maybe due to either loss of mental or physical activities, due to a disability. If you're in a nursing home, this benefit, you might be eligible for it, and it might kind of ease the cost of that a little bit. The other one as well is, if your eyesight is limited, obviously this can really impact your ability to go about your daily life and to sort of care for yourself, especially if you have other disabilities along with that, especially mobile disabilities. So even with things like glasses or contacts, if you have like really limited vision, even with that correction, you can also be eligible for this benefit. And then you might sort of think, okay, I don't have any of those quite, I am able to get out of bed. I have, maybe my eyesight's not the greatest, but I am able to get around, stuff like that. But I do spend most of my time maybe at home. Going outside is maybe more of a struggle for me. And so there is actually another type of benefit called the housebound benefits eligibility, where you can get around almost $1,900, about $1,800 a month for a married veteran, and about $1,000 a month for a surviving spouse. And you can be eligible for this sort of housebound benefit if you get a VA pension. And you have to spend sort of most of your time in your house because, of a permanent disability of some sort. So, the VA kind of offers a couple of tiers, a couple of levels that might kind of correspond to your level of disability or your living situation and sort of what challenges you might face in your life. So there's a couple of different levels. One thing to kind of keep at note here is you sadly can't sort of double up on this. You can't get aid and attendance benefits and the housebound benefits at the same time. So just to provide a little bit of a clarification on that. Next slide, please. So you might be thinking, okay, this sounds actually really nice. This would actually really ease, either my living costs or the burden, maybe for a loved one who might be attending to me in a lot of ways. How do I get in on this? How do I apply? Well, you can apply by submitting a form. It's the form 212680. So 212680. If you submit that form to the VA at your local pension management center, you might be thinking, where is that? Where is my pension management center? Well, there is a big one on the East Coast. If you live, in Georgia or really anywhere on the lower East Coast, your main PMC, your main pension management center is in Philadelphia. You might think, okay, I don't really, going up to Pennsylvania sounds nice, but that seems kind of far away. Can I send this somewhere else? Can I go in somewhere? You can actually take all your info to actually just a VA regional office. And there is actually one here at 1700 Claremont in Decatur. So if you just send your, if you just take your information from the 212680 there, they can also get you plugged in. Now, for this form, there is a separate section, section 3. This is where a lot of the medical evaluation is going to be done, like when the VA is trying to decide your disability level. This is the part that you'll want to take to your doctor. This is where they're going to start providing something of an examination. They'll be able to provide some, their own expert advice, and the VA will then look at that and sort of make the decision, on whether or not the aid and attendance benefit or the homebound benefit might be right for you. So yeah, that's really all you have to do is fill out that form, take it to your doctor to fill out section 3, and then send it to either Philly or bring it here in Decatur. So yeah, and then next slide, please. So I'm going to go back to Carlissa here just to talk a little bit about VA disability eligibility.
Yeah, so when you all think about VA disability benefits, this is what comes to mind. And one wonderful thing about these benefits is that they are tax-free. So you all have heard the phrase, another day, another dollar, 50 cents after taxes. So very, very few times in life do you have the opportunity to get money. You're shaking your head, yes, without the federal government reaching their hand in your pocket and taking 50% of it back, right? So VA disability benefits, this is a tax-free benefit. And you can get up to $3,500 a month, depending on whether you're single, whether you're married, whether you have 3 kids, whether you have 1 kid living at home. But if you are service connected and you have a 100% disability rating, you're going to get around $3,100 a month tax free. So it certainly behooves you to apply for disability benefits if you think you are suffering from a condition caused by your time in service. So what are we really talking about here? 3 things are required for VA to be convinced that you have an in-service or a disability caused by your time in service. So you need 1, a current diagnosis, and you need 2, an in-service event or trigger. And finally, you need some sort of connection between 1 and 2, something we call a nexus. And this piece is extremely important because anytime you are denied for disability benefits, it's almost always because VA finds there's no nexus. And a lot of physicians call our office and they ask us, well, how can I write favorable nexus opinions that'll convince VA that my patient's condition was caused by their time in service. And VA is really tricky and sneaky and squirrely, and they like to see magic language. And if they don't see that language, they like to stamp a big old denied on your VA disability application packet. So one thing your doctor has to say is condition X, more likely than not, was caused by my patient's time in service. And of course, everyone has different conditions and whatnot. But let's say you were airborne and you had a bad landing after a jump and you twisted your knee and now you have arthritis. Well, you're going to need the current diagnosis. So a medical doctor saying, I've diagnosed you with arthritis. You're going to need that specific event or trigger. And so how are you going to prove that? Well, maybe you had buddies with you. So you can get something called buddy statements. Maybe 3 or 4 people who served with you also jumped that day, and they're well aware that when you landed, you twisted your knee or broke your leg or whatever it was. But maybe also you went to a physician after you had that bad landing. And so maybe you have some medical documentation from that day. Another thing would maybe be orders. Maybe you were deployed and you suffered an injury while you were deployed. So maybe you still have those orders. But then again, you also need that letter from your physician saying, yes, the arthritis, more likely than not, resulted from the bad landing that my patient, had after jumping from, I don't know, a C-130 or whatnot. Okay, so that's what you really need for VA to approve you for VA disability benefits. And this is just a list of examples. And there are many different things that could potentially be connected to your time in service. So maybe you have chronic back or neck pain. Maybe that's the result of those long road marches that they force us to do in the military, where you have to haul around half your body weight, or in my case, 70% of your body weight for miles and miles on end. Maybe you have tinnitus. Some people say tinnitus, but this is very common among veterans because we go to the firing range often, don't we? Something like TBI, post-traumatic stress, even something like major depressive disorder or generalized anxiety disorder could potentially be caused by your time in service. Another thing is exposure to toxic chemicals. So if you were in Vietnam, more than likely you were exposed to the defoliant known as Agent Orange. And there's a whole list of conditions that have been connected to Agent Orange exposure. Okay, and now we're going to talk about survivor's pension, and this is for spouses. So Andy's going to come up and talk to us about this, and this will speak to Dr. Parker's question from earlier.
Great. Thank you, Carlissa. So yeah, I'm going to talk a little bit about VA survivors benefits. And this, this is a really common and really understandable worry, after I die, like, can I make sure in some way, at least a little bit that my spouse who, is able to see some sort of benefit, is able to live a little bit off of my, from my service in some way. And this is what that is about. So, you might be eligible for this benefit if you haven't remarried after the veteran's death, and if the deceased veteran didn't receive a dishonorable discharge, and the service has met sort of one of these sort of main areas. So this is sort of done chronologically, a little bit by time period. So for instance, if you entered active duty on or before September 7th, 1980, and you served at least 90 days on active military service, and you spent at least one day in a covered wartime period. So that's one of those categories. If you served a little bit after September 7th, 1980, it's 24 months or the full period by which you were on active duty, and also one day sort of during a covered wartime period. So this might be something like a little bit after. This might be like the Gulf War or something like that, or Iraq. Or, as, these benefits as veterans of some of these wars are starting to get a little bit older, and are also starting to think about retirement and starting to think about benefits. Or if you're an officer and started an active duty after October 16th, 1981, and you hadn't previously served on active duty for at least 24 months. So there's kind of 3 different categories here, kind of depending on the situation you're in, whether you're an officer, when you entered, and so there's a few different categories that you kind of fall into. And this also, so as long as you fulfill one of these 3, you're in good shape. The last thing has to be true no matter when you served or if you were an officer. The last thing is this, that your yearly family income and net worth is less than $138,400 $489. I'm not totally sure where they came up with that exact number, but that is it. $138,489. Now, you might be thinking, how do I calculate this exactly? Well, your net worth is sort of made up of a few things. And basically what it is you count, for instance, your savings, your checking accounts, any mutual funds, any stocks you might have. You don't count your primary house. If you have a house that is your residence, you don't have to count that in. You don't have to count your primary car as well. And it says most of your home furnishings, I would imagine, so in the most basic things, probably your bed, probably your dresser, stuff like that. So it's kind of everything else, everything except the very bare basics. You can kind of count into that net income. And as long as it's below $138,489, then you might actually be eligible for this benefit, or rather your spouse can be eligible for this benefit. So this is a really helpful thing. And, hopefully that addresses a little bit of that concern. And hopefully addresses a worry that I know many of y'all might have, about what happens to your spouse, what after you maybe pass on. So that's about it. And then next slide. This will actually go back to Carlissa to talk about the dependency and indemnity compensation, often called DIC.
Yeah, so DIC, and we've actually represented several veterans' spouses in DIC claims. So if you are a veteran and you are receiving VA disability benefits and you pass from a condition you are service connected for, those benefits can pass on to your spouse after your death. So this is a very important benefit that will help your spouse, after you're gone, because this too is up to $3,100 a month and it's tax free. So basically the benefit that was going to you as the service connected veteran passes to the spouse after you're gone. So there are a few eligibility requirements. One of them is that you lived with the veteran without a break until their death. Or if you're separated, you're not at fault for the separation. And a lot of people have questions about this. So VA does not want to encourage people to stay in, let's say, physically abusive relationships. So if you are married to someone who is abusive and for your own health and safety, you move out of the home, for that reason, VA will go ahead and consider you eligible, even though you're not currently living with the deceased veteran. You also have to have married the veteran within 15 years of their discharge from military service. And these are ORs, sorry. So these are ORs. You were married to the veteran for at least 1 year, so that's not too long, or you have a child with the veteran. So these aren't, I don't say these are too strict. Most people can say they at least married the veteran within 15 years of the discharge, they had a child with the veteran, or they were married to the veteran for at least 1 year. But again, this basically just transfers the benefits you were getting as a service-connected veteran to your spouse. And this does not happen automatically. So your spouse, upon your death, does have to fill out a DIC claim form. So those of you who are currently receiving VA disability benefits, you need to make sure you're taking care of your spouse now and letting them know that they need to fill this form out upon your passing. Surviving children. So VA disability benefits can potentially pass to your surviving children. And there are stricter requirements VA has for benefits passing to surviving children. So your child cannot be married. Your child must be under 18 years old unless they are in college, in which case the age rises to 23. And the child can't be included on the surviving spouse's compensation. So stricter requirements here. It's easier to get these benefits as a spouse than it is as a child.
Okay,
but
guys.
it's possible.
We're gonna have to stop here.
Thank you.
And because we do want to honor our veterans, we know that they do have some questions for you, and we want to try and get a couple of their questions
Sure.
before you guys leave. So
Sure.
real quick.
Please note that February
Aye.
17th is an upcoming Wills Clinic for military veterans. Just need to know where, Carlissa.
Yeah, so we're actually meeting with veterans virtually by Zoom. We did bring some Wills intake forms today in case any of you are interested in our February 17 Wills Clinic. We do have a couple slots left. We're almost at max capacity, but I'm happy to pass those forms out if you need them. We will do Wills, POAs, and advanced directives for healthcare.
Send them in ASAP if you do want to be a part of this. We only have a couple slots.
And you're going to tell us where. Okay. Next,
Couple of
Mr.
things.
Graves.
Couple of things. First of all, the charge for those that don't fall within that low income. Do you have a charge or a rate sheet for those veterans?
So as of now, we're only providing services to low income veterans, and those services are free of charge. If you are an upper income veteran, we do have a couple law firms in the Atlanta area, and their attorneys are military veterans, and they're very familiar with this type of work, and we would, give their names out for a referral.
Okay, and the VA aid, is that if you're receiving retirement or disability benefits or both?
So VA aid and attendance is a completely separate benefit than VA disability benefits or retirement pay. Are you asking if you can kind of triple dip and get all three, or what exactly
No,
is the question?
I'm asking, does that VA aid pertain to, you said, is that retirement income? If you're receiving retirement income, or maybe you got a veteran that's receiving disability income but did not retire. So are they eligible for that aid in either or both circumstances?
Yeah, as far as I can tell, this is meant to be sort of a supplement, especially for those who might, especially for those who are kind of taking the time and everything to attend to your, if you have that kind of disability. This is meant to be a supplement. The only thing that the VAA sort of can't go with is you can't have that with the homebound one sort of at the same time. But if you're collecting, for instance, let's say some Social Security, you're also having maybe a VA pension or something like that, this can also go right on top. Because especially once you have these more severe type of disabilities, it just gets more expensive. And so the VA doesn't want to necessarily make you have to decide between a couple of these types of pensions. And so that is okay. It can stack in a sense. The only thing that you can't have together is the VAA and the homebound benefits. Those you have to choose between. But the rest, they can stack in that way. Yeah. That helps.
So there was a question concerning the net worth. Does that also contribute to the net worth in terms of the actual monetary benefits?
I do not think so, actually. In terms of do you count all the general pension payments and stuff? So this is actually the ones that you'll add up together, as far as I know. And so it's the value of everything you owe plus things like your accounts and stuff. So I don't think you count in your VAA and stuff.
Yeah, you'd be looking at your checking accounts. Some people own more than one home. So while your primary residence wouldn't count, if you have a beach house in, Charleston or something like that, then that would count. Oh, he's not talking about the survivor.
Oh, okay. I'm sorry. Yeah, actually, not that I am aware of. I don't think there is a requirement on that. So long as you meet those disability requirements. Yeah, and you're receiving a VA pension as well. Mm-hmm. Yeah, sure, no problem.
You have a question over there?
Question on just basic health coverage for those that don't qualify for any type of disability, just regular health insurance.
Are you talking about TRICARE? TRICARE is available to members who have retired from the military. And that's available whether you have, a disability from the military or not. Is that what you're asking about?
No, not TRICARE. Just basic health coverage if you retired but didn't retire from the military.
Want to know if the VA provides that?
Yes.
Okay.
Yeah, so the military has a federal funded basic health care coverage called TRICARE, but you have to actually have retired from the military to take advantage of that. The VA doesn't have a program whereby they just provide you with free, health care. Let's say if you just served for 4 years and you didn't receive any injuries or anything like that. But if you did retire, whether you received any injuries or not, you might be eligible for TRICARE.
Along with the pension and also possibly the survivor's benefits for the spouse as well, if you served. Yeah.
Okay, I think we have time for one more question.
Okay.
Okay.
Regarding the form number 21-2680, let me thank you for that information because I was talking about that on the way over here today. However, I did not know the form number. I will before I rest my head tonight. Yes. Regarding that particular form, you mentioned that section 3 has to be completed by a doctor.
Yes, sir.
Does that specifically state the VA doctor or your PCP doctor? And you follow up my last comment on that in that area regarding what the VA called VA math schedule. Can you guys circumvent that because it's not basic math? The VA have their own methodology in doing math to average out the VA benefits, which is really, in essence, penalizing the veterans for the inability that the VA is actually doing.
Right.
Yeah, so the VA uses something we often call fuzzy math, where you might be 70% disabled for one condition and 30% disabled for another condition. So you and I being normally functioning human beings, right, might think, well, 7 + 3 = 10. So I'm 100% disabled. And the VA comes in and says, no, you're not. Because what they do is they take a whole person approach. So if you have one condition where you're 70% disabled, then they say, okay, you're 30% whole. And then they subtract from there. So 70 + 30 doesn't equal 100, unfortunately. And a lot of people are very confused and frustrated about that. But yeah, the VA uses fuzzy math.
Okay, final question. Now's a good time to complete your post-event survey, and then Dr. Parker has some money to give out. Last question.
I think I actually forgot to answer the first part of this gentleman's question because he asked if it had to be a VA physician fill out part 3 on the form. No, it does not have to be a VA physician. So if you are currently seeing a private physician for a condition, I would recommend you take the form to the private physician and have them fill out section 3 of that form. It does not have to be a VA physician.
Okay. Question?
I just have a comment on the TRICARE. TRICARE, you have to be retired or medical retired from the VA.
Right.
I mean, from the military. Now, if you're 100%, the VA, you will be eligible for champions. That's another free insurance. But all veterans are eligible to go to the VA for help for medical. But I think it's a couple of them that they will not see you for, but as far as your health concern, you're able to go and get that checked. But remember, the 100% it take about 200% become 100% in the VA.
Yeah, fuzzy math.
That's fuzzy math, yes.
Okay. Okay, David, am I good for questions? I think he's saying yes. So thank you, Carlissa. And thank you so much for coming. Just a reminder, one last thing, Carlissa. You said a website and you told us when it was, but I didn't see the website to get it. Just email you. So she has forms if you're interested in participating in that clinic on February 17th. And it is virtual. It is not in person.